Good morning, everyone. Once again, welcome back for our weekly mock test. Today I'm Dr. Munjal Pandya. For those who are new to the group, joining first time, just quick introduction. I'm hemato-oncologist and bone marrow transplant fellow practicing for more than 20 years now and academic experience of more than 10 years teaching and coaching, and I would like to take you to the excellent journey of interesting new MCQs. Some people keep asking me questions are same or repeated. So let me remind you all in in mock test, not a single questions will be repeated in every week. So it's all new. Dr. Maddy is our internal medicine, Dr. Ankit, Dr. Shikhar, now Dr. Mariam J. Hellard, she's also joining our team. I mean, she already joined, rather, I can say she delivered 3, 4 lectures and she's from US and she joined recently with the medical MCQ for all. Our team, and there are a lot of people with Pallavi, Anjali, and many other backup support team. This is our contact detail, our hard copy book. We provide everything, including online coaching, subscriptions, a lot of promo codes, big discounted things. So you can inquire later on, right? And let's, last but not the least, data flow, exam booking, and related things. License transfer or any exam or data flow related things will be done from Dubai by Dr. Anjali and our team. So feel free to contact and lots of discounted as told you more than 60-70% plus. So if you guys are interested, you just later on. Last but not the least, strong recommendation to subscribe the YouTube channel. Hundreds of like this what I am taking today. Same mock test if you have missed earlier, you can catch all the videos on our YouTube channel. And let's jump to the 19th today's our mock test. First questions in front of your screen. A 22-year-old woman is found unconscious in a room by her boyfriend and brought into the accident and emergency. Urine dipstick is positive for the glucose and ketones, and blood analysis shows following results: pH 6.9, PCO2 3, PO2 13, sodium 144, potassium 5, urea 11, glucose 20 millimole per liter, chloride 100, bicarbonate 2.9. The most likely anion gap is 180, 118, 139, 46.1, and 28. Take your own time. These all are questions related and asked in the previous exam for sure. So I came up with excellent MCQ. Always remember my triad, right? You need to know the three things: diagnosis, investigation, and treatment, right? This is a basic these things. If you practice this for each and every MCQ, believe me, you will be a master in 1 month. You need to know three things for each MCQ. So now you can make answer in your chat box. We'll discuss in detail, right? You can calculate. Is there any calculator? You can calculate. Dr. Noha, any calculator with you to measure the anion gap, Dr. Noha?
No, sir.
Any comment? Any comment? How you gonna answer these questions? Today's mock test would be every time's mock test is eye opener. This is the today would be more eye opener. So you get to know, do the self assessment. I don't need to ask you the score. You assess yourself, not you in general, everybody who is attending the class. So you have to be more sincere for your preparation. Fair enough. Anyone wants to try this? So far, I did not get any answer in the chat box. Not a single answer. We are more than 20 doctors already been joined, right? Yes. If this questions comes in your exam, how you gonna respond? Yes, Dr. Mutul. So let's start with you as you posted the answer. So now tell me, Dr. Mutul, what is the diagnosis in this patient? First of all, we are not in hurry. What is the diagnosis in this patient?
Diabetic ketoacidosis, sir.
Excellent, wonderful. Diabetic ketoacidosis. Can you compile all these three things, diabetes, ketosis, and acidosis in the things? So yes, right. This patient
Uh,
has a 20
has
20
glucose of
glucose.
20, so it is more than 400.
Yeah, so multiply in general with 18. When it is
18.
millimole per liter, multiply by 18 is roughly 360 milligram percent. Am I right or wrong? Yes. So this patient has a high sugar, so it is a diabetic patient. Simple, no need to mug up. Ketosis, how do you get to know if this patient has a ketosis? So glucose is positive in dipstick, ketone is also there, right? So ketosis is also there, right? And how did you get to know, Dr. Mutul, that there is acidosis?
pH less than 7.3, sir. 6.9 is the pH of the
Very,
patient.
very brilliant, very brilliant. So normal is this is like a speedometer, right? If it is less than this, it is acidosis. If it is more than this, alkalosis. 7.35 or less, anything less than this, acidosis. Here, what is the pH is acido 6.9. So 6.9 is acidosis. So we qualify the first thing diagnosis, diabetic ketoacidosis. This is how you have to remember in exam. You don't need to mug up, right? So, and here the diagnosis is diabetic ketoacidosis. Fair enough. Now, let me ask you, Dr. Mudul, how did you calculated this 46.1? Because 90% of the doctor doesn't know the formula, right? They don't know anything. How did you get this?
It is anion gap is a gap between cations and anions in our body, sir. It is sodium plus potassium minus chloride and bicarb.
So everyone should remember how this sodium plus chloride, sodium plus potassium, sorry, right?
Sodium plus
Minus
potassium minus
minus
bicarb and chloride.
chloride plus bicarb, right? So put the values
Yes,
one by one. So what is the sodium here? They had given the sodium
144
here. They have 144. So this is
plus
144.
5.
Potassium, look, I'm just trying to explain everyone, you knows well. So 5 is a potassium. So this is sodium plus potassium minus chloride. So chloride is 100. So this is chloride is 100 plus bicarb. Bicarb is 2.9. So it is 2.9. So what is the final? 149 minus 102.9 is equal to 46.1. Is that correct? Yes or no? Is that correct? Yes or no?
Yes, sir.
So this is how the anion gap comes, right? So everyone should know the formula of anion gap. This is recently asked questions in the exam of DHA. Calculate the anion gap. So I got these questions from there. I little modified it, right? So formula to calculate the anion gap is sodium plus potassium minus chloride plus HCO3. That's it. Whatever the numbers they had given, nothing to worry. You just need to put the figure and finally you may need to make one number, right? So this is what the anion gap. Is there any questions to anyone?
Sir,
Is it clear to everyone? Yes or no? At least tell me yes or no. So I know
sir,
you
one
are
Yes,
with
question,
sir.
sir.
me. Yes, please.
Sir, there's a one more formula, sir. Sodium bicarbonate plus chloride minus sodium minus bicarbonate plus chloride.
Yes. So this formula you can see on the screen. So first formula is sodium plus potassium minus chloride plus HCO3, right? And
Yes,
another,
I got
as you rightly
41,
told,
41, sir, in that formula.
yeah, so in 41, so 41 is not in the option. That is
Yeah.
why I posted the two things, right? So if you post sodium plus potassium, then you can get the 46.1. So these are the two formula you need to know, right? Anion gap sodium plus potassium minus this. Second formula is this, right? So this is very basic. Now let's come to the next questions in the same diabetic ketoacidosis. If the patients of diabetic ketoacidosis comes to you, Dr. Mutul, what is the first line treatment for this patient? How you gonna start the treatment for this patient? DK patient comes to you, right? So we see the triad. What is the diagnosis? We make a diagnosis of DK investigation. We send the ketone, we send the urine, and now you want to treat this DK patient, right? So how you gonna treat this patient? What is the first line treatment? What is the first thing you do? What is the second thing you do? What is the third thing you do? And what is fourth thing you do? You have a one patient in your emergency room. You diagnosed, right? Patient came with acidotic breathing. He has high sugar. He has a high respiratory rate. Patient has probably history of infection or fever. Or patient has a known case of diabetic. He missed the insulin and now came into the emergency with diabetic ketoacidosis with acidotic breathing. Now, how you gonna treat?
Insulin glucose, sir.
So first will be correction, rehydration. Rehydration of the patient in 3 hours, and then we'll start the insulin as per the sliding scale.
Wonderful. So first and foremost, never ever forget to do the right, correct the dehydration, or you can give the good
So,
hydration because this patient has
so
a
we'll do
polyuria.
hydration, then we'll give D25. We will neutralize the D25. Then we'll give
Wonderful.
nebulization so that the potassium will be
Excellent.
influx to the cells, sir.
Excellent.
And
That's
then we'll,
perfect. That's
yes.
perfect. That's perfect. So first, basically, your mind should be clear in any emergency. First, you gonna give the hydration to the patient. Preferred is a normal saline. So you give the good bolus of normal saline and continue. These patients are dehydrated patients, polyuria, urine, water is lost. So first do this. Second immediate step is to do the GI drip or glucose insulin drip, right? Or insulin, sorry, insulin drip. So insulin, can anyone tell me what is the dose of insulin generally? If you give patient, any patient, you start on IV, right? Or you want to start subcutaneously, you decide. You give me the answer. You want to start IV or subcutaneous or intramuscular, or how you want to give insulin? Insulin we want to give. How we
IV
gonna
as
give
per
the
the
insulin?
insulin pump, sir.
IV. Okay, fine. So one thing is confirm IV. Now, second question in this is dose, because those who don't know the DK, I request, humbly request, go and read complete chapter, not one thing, complete chapter. This is high yield questions. That is I'm discussing detail in the MCQ related with DHA HADMOH. So IV, what is the dose? Can anyone tell me the dose? What is the dose?
10 units loading dose, sir.
How much is
Actropid.
the dose? The
Point
dose.
point
Patient
one
as a patient is a 50 kg male patient. 50 kg male patient.
point one
So 0.1 unit per kg per hour. This is IV. Is that clear? Yes or no? Right? So 0.1 unit per kg per hour. So you have to start this. Once you started the hydration, once you started the insulin, what next correction you will going to do for this patient?
Potassium.
Next, fine. So you need to
Potassium.
correct the electrolyte, mainly electrolyte, especially potassium, right? If potassium is low, you need to give KCl. If potassium is high, right, you need to stop the KCl drip, right? Potassium chloride, right? So what happens? The basic pathology is this, right? This is the cell, this is the cell, and this is the plasma, right? So in plasma, the glucose is very very high, very high. And what the insulin do? Insulin will do, right, from plasma to the cell. This is the main job of insulin, right? So plasma blood glucose will reduce, diabetes will be under control, right? And glucose will be going into the cell. But what happens insulin? It will not just pushing the glucose into the cell, it is also pushing the potassium into the cell. So what happens, right? On insulin, patient may have low sugar, patient may have low potassium in plasma. Is that clear? Yes or no? At least tell me yes or no. Right? So you need to keep watch on the sugar as well. So 1 hourly you need to monitor, at least 1 hourly you need to monitor glucose, 1 hourly you need to monitor the potassium, because the side effect of insulin is hypoglycemia as well as hypokalemia, right? So you don't very much high potassium, you don't very much low potassium. So you need to monitor and you need to adjust. If it is potassium is very low in the plasma, means less than 3.5, you start the KCl drip. It is more than 5.5, this is normal range, 3.5 to 5 point. Then you can have to stop the potassium, or you can omit the potassium, right? So third thing is electrolyte disturbance correction, electrolyte correction. What is the next fourth step in the patient's management of decay? Anyone?
Control the infections.
Control the infection. That is also excellent in pod infection. So control the infections, right? So you can give the IV antibiotic as well. Control infection means giving the IV antibiotic. So cases of fever, cases of increased total count, leukocytosis, right? These are the all indications to start the antibiotics, right? Antibiotics. So these are the four common steps in management of any diabetic ketoacidosis. You don't need to mug up. First, you hydrate the patients well. Also, you give the insulin, right? You also correct the electrolyte, and if there is a sign or symptoms of infection, you must treat this infection, right? So this is how you have to generate the protocol. You don't need to mug up, right? So this is the basic, right? Any part of the world, any emergency room, this is followed, right? So you must know what is the things, right? So this is the thing. Another question with diabetic ketoacidosis, which is the worst prognostic factor? Diabetic ketoacidosis, which is the worst prognostic factor? Let me ask you the question. Worst prognostic factor in patient of diabetic ketoacidosis? Four options. Very high sugar, like 600 sugar. Second is a presence of ketones in the blood or urine. Third thing is a increased respiratory rate. And fourth is a serum bicarbonate. Answer, please.
Serum bicarbonate.
Recently asked questions in exam. So answer is serum bicarbonate, right? Sugar high 600, 700 doesn't make much difference. But if your serum bicarbonates are low, right, this patient has high risk of mortality, means death, high risk of mortality or death. So these are the questions related with diabetic ketoacidosis. So always keep in mind. So this is the formula. I already told you sodium plus potassium chloride HCO3. Normal anion gap is 10 to 16 millimole per liter. Corrected answer is 46 point. So this is all the number we put and got the 46.1. So let's get back to the our routine main stem of the questions from where we started, right? So this is what the thing is, right? So answer is 46.1. Let's move to the next question. 45-year-old Asian man. So those homework. Today's homework is to go and read diabetic ketoacidosis completely from first line to last line. 45-year-old Asian man is diagnosed with Cushing disease. In India, he undergoes a bilateral adrenalectomy and recovers well from the operation. On his return to the UK 1 year later, he complains of constant dull headache, peripheral visual disturbance, increasing pigmentation of the skin, creases in the both hands. Most likely diagnosis is ectopic ACTH secreting tumor, pro, uh, prolactinoma, Nelson syndrome, Addison's disease, side effect of iatrogenic steroid intake. Take your own time. I'm not in hurry at all, right? So take your own time and try to answer this question. And as usual, you can have a look at it. The questions you need to see definitely to get the proper answer. So here, first of all, our triad. What is the diagnosis here? What is the investigation? And what is the treatment? So this is our triad, right? Triad contains three things: diagnosis, investigation, treatment. Take your own time, think over it, what it could be, we'll discuss. Yes, Dr. Abid.
So, after the areolectomy, with the complaint of a dull headache and this peripheral visual disturbance,
Mm-hmm.
so of the options, as I can see only prolactina, which can be more the closest doing this.
Okay, so what is so how did you get to know? Because this can thing in ectopic ACTH, this can develop in Nelson, this can be seen in Addison's, this can be in other conditions as well. So
But
how
so
you
the
differentiate?
in prolactinoma, sir, patient the adenoma of the prolactin gland, there can be sir dull headache can be seen also, sir, and this peripheral visual disturbance can also be there, and the increase
Mm,
in the pigmentation, sir, I think, sir, there is a same gland that secrete the melanin, sir.
mm.
So from
Which
there, I
gland
was
secrete the melanin? Which gland secrete the melanin?
MSH, sir,
Yeah, which gland secrete the MSH?
anterior pituitary.
Anterior pituitary. Okay, fair enough. Then what posterior pituitary will release?
So oxytocin,
Only oxytocin.
oxytocin, and yeah, so that uh,
And the one more
Education.
thing.
ADH,
The
is
vasopressin, oxytocin and
Vasopressin.
vasopressin.
and this
Oxytocin.
which
Oxytocin and
concentrate the urine, sir?
vasopressin.
I'm
Yes,
forgetting the
ADH,
ADH, sir.
antidiuretic hormone.
Yes, sir.
Sorry, I'm checking your general knowledge as well along
Yes,
with
sir.
this. So lots of brainstorming. So is it prolactin level is high in plasma? Number one question. It is classically gynecomastia in prolactinoma. Is it there in scenario? Patient may have infertility, especially man patient infertility. Did you get all these three symptoms or this classical finding of prolactinoma in this patient?
No, sir.
Then what it could
No.
be?
The answer A.
Answer A. So let's
It's
discuss for A because we need to rule out all the things one by one. My job is not just to give you the answer. My job is to rule out one by one all. Why not this? Why not this? Why not this? Why not this? That is learning. Fine. So let's see. So anybody can. Dr. Nasrin, why it is ectopic ACTH secretion tumor?
So
Let's
increasing pigmentation of the skin, this is the presentations we can go for ectopic ACTH.
okay. So ectopic
I think
ACTH
it's
means what?
Nelson syndrome.
One minute, one by one. We'll discuss. Yes, Dr. Nasrin. Ectopic ACTH secreting tumor means what? Little, can you little define what you understand by ectopic ACTH secreting tumor?
It's a kind of paraneoplastic, like it is not actually related to the adrenal, but some associated paraneoplastic syndromes we can.
Paraneoplastic syndrome. Okay, so can you give me the commonest pathological organ or site or malignancy where you get the ectopic ACTH secretions of the tumor?
The squamous cell carcinoma of lungs.
Squamous cell carcinoma of lung. So basically lung cancer. Right.
Yes.
So is there any history of patient has a more than 50 years, smoker, constitutional symptoms, weight loss, chest pains, shortness of breath, hemoptysis? Is it in the scenario?
No, sir.
Fine, fair enough. So it is not there. Then how did we get to know that it is ACTH secreting tumor then? Because there is nothing like, I mean, squamous cell carcinoma or small cell or lung cancer can produce ACTH like hormone, right? And that is
Yeah,
why it is
yeah.
a paraneoplastic syndrome. But it doesn't looks like this. And he is a known diagnosed as Cushing syndrome. So primary pathology is a
Yeah.
Cushing syndrome. Primary pathology is a Cushing's disease. He has a Cushing disease. He has a Cushing
So
disease.
one thing can be, sir, after the adrenalectomy, might be advised to take a small amount of steroid. So option E can be there also, sir.
Mhm. Okay, so now this is gone basically, right? Prolactinoma is also gone. Now, side effect of iatrogenic steroid intake. Side effect of iatrogenic. What do you mean by iatrogenic? Can you
Unknown.
tell me? Right. So why this patient is taking steroid after 1 month? Right. He underwent for bilateral adrenalectomy 1 year ago. Right. It's recovered well from the operation. He says bilateral adrenalectomy recovers well from the operation. Right. And on his return to UK 1 year later, he complains of this. So 1 year in within 1 year nothing happens. 1 year nothing happens. He's not on any medication. Nothing is mentioned here that he is on these medications, blah blah blah. If it is there, then they could have been mentioned here. So any other comment? I'm trying to do some brainstorming. You understand? We need to understand. We don't, otherwise I can finish in half an hour. Whole mock is done. But we'll not learn. Here we'll learn. Anyone, any comment? Dr. Sama, you I think told Nelson syndrome.
Yeah, I think I just remember Nelson syndrome is due to the after adrenalectomy surgery and the negative feedback reaction just caused the macroadenoma or which secrete the ACTH secretion, adenocorticotropin hormones. Just
Excellent. 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 So answer is a Nelson syndrome. Now tell me, Dr. Sama, as you have some clarity, Nelson syndrome is exactly what? I mean, what happens in Nelson syndrome?
mm, Nelson syndrome. This increase secretion of the ACTH hormone, like symptoms like dull headache, it's mentioned, and the peripheral
Fair
disturbance in the
enough. So this clinical
intrinsic.
symptoms happens because of Nelson, but what happens for the every doctors to understand what exactly Nelson syndrome means? If you want to give the definition of Nelson syndrome, what one-liner or two-liner definition you can able to give?
Mm,
Right, absolutely. Answer is Nelson syndrome. I'm just trying to understand more your concept. what exactly you understand by Nelson syndrome. So, where is the pathology in Nelson syndrome? What happens in Nelson syndrome? How you can prevent the Nelson syndrome? So, let me come to the conclusion here with the literature. We will discuss everything with the literature. Without literature, we will not discuss. The chances of developing Nelson
Um,
syndrome appears to be a greater
pitu-
if
yeah.
adrenalectomy is performed at a younger age. This patient is a younger age, right? 45 is not very.
Uh, in
Yes,
Nelson syndrome, pituitary tumor continue to grow, so release the
correct.
hormone ACTH
Absolutely fine.
after the adrenal gland removed. That's it.
Excellent,
That's
excellent, excellent. So let me put it in a simpler way for everybody to understand. So Nelson syndrome is basically occurs because of bilateral adrenalectomy. So what happens when you remove both the adrenal gland? There is a inhibition of negative feedback mechanism, and from pituitary there is a overproduction of ACTH, right? Overproduction of ACTH, and this could be eventually become microadenoma of pituitary, or this microadenoma of pituitary can produce the excessive cortisol, right? Excessive cortisol, and this excessive cortisol is responsible for the symptoms what the patient has mentioned here, right? How you could have been prevented this? So either there are two steps. One step is you do unilateral adrenalectomy plus radiation to the pituitary, or you can do bilateral plus you can do the pituitary irradiation. So microadenoma will not develop and it will not release the excessive ACTH from the pituitary, because you also give some radiation and some treatment to the primary culprit which is responsible for this, and that's the explanation. So Nelson syndrome is basically a sequelae of post-adrenalectomy due to the excessive production of the hormones in the pituitary. Nelson syndromes occur in a patient who undergo bilateral adrenalectomy, and lack of negative feedback over time causes macroadenoma to form the pituitary which secretes the ACTH. A spectrum of the symptoms will develop. Why not ectopic? An ectopic tumor secreting ACTH can produce similar symptoms, right? Somebody told that it is Eve. They are fine. Symptoms are same. However, they usually originate from the oat cell in the small cell lung cancer, right, which are associated with the weight loss, right, rather than headache and visual disturbance. So headache and visual disturbance is not that common in ectopic tumor secreting ACTH, right? It is usually associated cancer, na? So constitutional symptoms of cancer is fever, weight loss, right, bone pain. These are the common, which is not there. And headache and visual disturbance is extremely rare in ectopic. Rather, they have more of weight loss. Iatrogenic side effect would be causing the imitating cortisol excess, such as stria, right? Iatrogenic steroid, what they can cause stria, bruising, thin skin, and weight gain, which is also not mentioned there in the scenario, so less likely. Why not prolactinoma? Prolactinoma can cause some of the symptoms that patient complains of in the scenario, such as headache and visual disturbance due to pigment upon the surrounding structure. However, symptoms in male does not involve hyperpigmentation and usually include loss of libido, impotence, infertility, and gynecomastia, and hyperprolactin secretion, which is also not there. So this is very less likely. None of the symptoms are present, which is of classical of hyperprolactinemia or prolactinoma. And Addison's disease is like not the answer, obviously, right? It is usually because of uh, autoimmune disease or infection, nothing is there. So in the context of the questions, right, classical, this is more favor of Nelson syndrome, as we discuss with these things. So those who do not know, right, about the Nelson syndrome, I request and urge to go and read once again. Let me go with the one of the questions which is also high yield with these things, right? Cushing syndrome and Addison's disease. Can any volunteer tell me what is the difference between Cushing syndromes and Addison's disease? So we go one by one. Cushing syndrome, what is the pathology? Or what is a, when you say it is a Cushing syndrome, when you say Addison's disease, right? Another is a etiology. Etiology, right? What happens to sodium? What happens to blood pressure? What happens to sugar? And what happens to potassium? And what's the treatment? Obviously, what's the treatment? Can anyone wants to try very quickly to check your knowledge of Cushing syndrome and Addison's disease? Absolutely high yield questions for any exam.
So addition
Come on,
disease is the
one by one.
autoimmune.
Okay,
Good.
so let me write down here for clarity of everybody's. It's a learning platform, so everyone wants to learn. So Addison's disease, you think it is an autoimmune disease, right?
Autoimmune
Addison's disease,
destruction, sir. In
autoimmune
Asian
destructions of
country, it
the,
is TB, and in
okay, in
Western world,
Asian
it is
country.
autoimmune.
Fine. So basically, these are the two things. In developing country, it's a TB. Developed country or Western world, autoimmune infection is less common, obviously. So this could be etiology. What do you think? This could be etiology basically rather than this. So this is etiology. So what could be the etiology in Cushing's? Here, Edison's perfect. Absolutely correct. What
So
could be
it's
the etiology
more
in
production of the
Cushing's?
steroid out here,
Yeah.
Cushing syndrome,
More production of the steroid or
Cortisol.
hypercortisolism or cortisol is
hypercortisolism.
increased,
Yes, sir.
right? So what are the causes of increasing steroid here?
So
Adrenal adenoma
adenoma.
or
Adrenal
bilateral
problem or
adrenal
adrenal
hyperplasia.
adrenal adenoma or adrenal problem. What else? This is the only one problem can cause Cushing's. Anything
Yes.
wrong in the pituitary can cause Cushing?
Pituitary tumors.
Yes.
Pituitary tumor.
Pituitary
Anything
tumor.
wrong in the hypothalamus can cause Cushing? Yes or no?
So exogenous
Yes or no?
steroid.
ECG.
These are the four reason, right? Or ectopic, you can say ectopic, like small cell, right? ACTH releasing hormone from the lung cancer or OAT cell that cause paraneoplastic syndrome and hypercortisolism, but the primary pathology is lung cancer, right? So ectopic production out of the out of the endocrine gland, ectopic. So these are the four possible way, probable hypothalamus tumor or hyper secretion or stimulation, right? Pituitary problem, pituitary tumor, adrenal tumor, and steroid. So this is the primary pathology. So treatment is not the one. If there is a pituitary tumor, you need to remove the pituitary tumor. If you have problem in the adrenal, you need to remove the adrenalectomy or you need to do the adrenal. If you are giving lots of steroid for collagen vascular disease, autoimmune disease, many things, either you need to switch to other problem to avoid the Cushing syndrome or Cushingoid symptoms. You need to do. So treatment is not one for all the things, right? Depends on the site, depends on the problem, depends on the organ where it is a problem. You need to treat accordingly. Number one. So this is reasonably clear. What happens to sodium? What happens to blood pressure? What happens to sugar? What happens to potassium? Because lots of people are getting confused in this. That is why I'm taking this point now. Anyone wants to try what
In
exactly
Cushing,
happens?
in
And could
Cushing, sodium is
but
increased, BP is increased,
1 minute.
potassium is reduced.
Okay, so sodium increase, BP is increased,
BP is
sugar
sugar
is
is
increased,
increased, potassium is
only
reduced.
the potassium is reduced. Excellent.
Mhm.
Completely the reverse. Completely the reverse. Sodium
Reverse in
reduced,
Addison's.
blood pressure reduced, sugar reduced, only increases potassium. So this is how I remember. Here everything is increased. Everything is increased. Cortisol increase, sodium increase, everything. Just remember in Cushing what reduced? Potassium. Addison's, right? Addison's, you can also call it as hypocortisolism. This is hypercortisolism. Na? Cortisol is releasing more, hypercortisolism. Fancy name is Cushing, right? And here the Addison. The Addison is the name of the person, right? So Addison's disease or hypocortisolism, right? Where hypo means all low, cortisol low, sodium low, blood pressure low, sugar low. Only thing will be increase is the potassium. Is that clear to
potassium.
everyone? Yes or no? Don't confuse yourself. Don't confuse yourself. I cannot deliver easier than this. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. What is the treatment then? If I ask you, what is the treatment of Cushing? What is the treatment
Underlying.
of underlying cause? As we discussed, right? Where is the problem? Where is the problem? So underlying problem, you can do. Is there any drug? Is there any drug? Is there any drug which can reduce the cortisol? Can you name? Can you name the any drug? Can you name any drug which reduces the cortisol?
Hmm.
Home homework. Write down your homework. You need to know what is the pharmacological treatment of hypercortisolism. This is all basically a surgery, right? Wherever the tumor, you remove the tumor. And Addison's disease, what's the treatment?
Steroids.
Dexa. Dexamethasone.
Hydrocortisone.
Yeah, so basically steroid supplementation,
Mhm.
right? Dexamethasone or hydrocortisone, right? So steroid is the treatment. So this is what the basic of Cushing's and Addison's. Second homework, first is a diabetic ketoacidosis, second is a Cushing's, and third is Addison's. So you go and read it, right? So I try my level best to make it more easier for you. Third questions in front of your screen. 24-year-old, check your score, right? If 2 out of 2 correct is good score. If your score today is less than 60%, not good score. So you measure by your own. I don't need to check each and every individual how much is your score, but you should assess yourself. Where are you standing before the exam? Very important. 24-year-old man present with a notably slurred speech stating, I don't want to live anymore. I just want to take pills and make the pain go away. A psychiatric history reveals that the patient has suffered from a major depression for 9 years and had numerous psychiatric admissions for violent behavior and has attempted suicide twice by overdose. The patient currently has a blood alcohol level of 0.012. Which of the following is patient's most significant risk factor for a completed suicidal attempt? Anti-social behavior, depression, male gender, past suicidal attempts, substance abuse. Yes, Dr. Nasrin. I think probably your answer is a male gender. So let's discuss little bit, Dr. Nasrin, if you are comfortable.
Yes, sir.
What is your answer? What do you think? What is the most riskiest thing for these patients for suicide attempt?
The genders, male gender.
Male gender.
Yeah.
Male gender. Okay. Any other comment? Lalita? Dr. Lalita?
Yes, sir.
What is your answer?
Sir, I think C or
C or
B.
B? B means
Yeah.
depression and C means male
Depression
gender.
and male gender.
Okay. Yes, Dr. Maria?
Sir, I feel antisocial behavior is the correct answer for this.
Antisocial behavior. So what is antisocial behavior? What do you mean by antisocial behavior? There must be something, na? Antisocial. So how did you how you can recognize that this patient has antisocial behavior from the scenario?
So before 18 years, it's a conduct disorder, and after 18 years, it's an antisocial behavior, like putting on the fires, hitting back,
Mhm.
selling drugs.
Fair
This
enough. So do you think this patient antisocial behavior has the
no, sir.
highest risk of suicidal attempt,
The past suicide attempts, sir. The answer.
past suicide attempt? So there are three, four answers. Somebody is saying antisocial, someone is saying male gender, someone is saying depression, and now this is the fourth answer, past suicidal attempt. Yes, Dr. Sharma, any comment? All are interesting questions. All comes in the exam. Yes, Aishba Neha, any comment? I want to attempt everyone. Try everyone. No? If you think if the same questions comes in your exam, how you gonna react? Don't take it lightly that oh it will not come.
I think it's a
It
pass.
definitely come. Fine. So answer and literature. So literature and answer says many studies have found that the greater risk for the completed suicidal attempt in any patient is whether they have attempted suicide in the past. So past suicidal attempt is one of the biggest risk factor. The recent research shows, in fact, some research shows past attempt may increase the risk of suicide by 22 times. And it is also important to assess whether patient has a plan for suicide or not, right? Whether the suicidal attempt was by lethal means, right? Antisocial behavior, depression, male gender, and substance abuse all can increases the risk of suicidal attempt complete, but the biggest risk factor for suicide is the past or previous suicidal attempt. Now tell me, what is the treatment? If some patient, same patient comes to you, now you want to treat, how you gonna treat this? Change the questions. Answer is past
Can I
suicidal
ask
attempt.
one question?
Yeah, please.
Sir, if the question doesn't mention regarding the past history of suicide attempt, then what should be the answer then?
Then depression.
Okay, sir.
Depression is another biggest, right? Antisocial is also there, but they are more kind of aggressive than depression. So depressed patient has lots of suicidal ideations, right, in the mind, right, and they come
Yes.
and they commit, right? So what could be the treatment here? What could be the treatment here?
So
Treat
electroconvulsion,
this patient. Sorry.
electroconvulsive, sir. Shock.
Cognitive behavior.
Hmm.
CBT.
So let me write down the list of the treatment. Then we can discuss. One treatment is a
Cognitive.
ECT, electroconvulsive, cognitive behavior therapy.
Yes.
What else? That's all. These two only. Any pharmacology treatment available? Those who wants to commit suicide or no available?
Antipsychotic, antidepressant.
Antidepressants.
Antidepressant.
Antidepressant. Okay, I'm making a list. Antidepressant. Anything else? Anything else? Anything anybody wants to add? That these are the treatment of patient with suicidal ideation. Let me ask, if the patient comes to you and tell you that I want to do the suicide, right? Or he has already two, three, four times attempted. What do you think? What could be the best treatment? These are the three options: ECT, cognitive behavior therapy,
ECT.
antidepressant.
ECT.
So answer is ECT, electroconvulsive therapy. This is
+3.
the fastest way. Any antidepressant will not work before 4 to 6 weeks or probably 8 weeks. Today you start the treatment and tomorrow they won't get the effect of SSRI or antidepressant drug, right? So you need to do something urgent. You need to do something quick fix for them, right? So ECT is one of the most important therapy for the patients with the suicidal ideation. This could be exam questions. That is why I noted. Let's check the cardiology and ECG now. All questions are different, different department, different subject. 80 years old woman is admitted to the ICU for acute pulmonary edema, right? Sorry. You should know the treatment of antisocial behavior. You should know the treatment of depression. You should know the treatment of substance abuse, and you should know the treatment of past suicidal. Your duty is not just to get the know the answer. Your duty is to know each and everything in the scenario. So this is also homework. If somebody doesn't know what is the treatment of antisocial behavior, pharmacological therapy, go and read it. 80 years old woman is admitted to ICU for acute pulmonary edema. She has aroused to the apices and JVD, jugular venous distension. EKG shows ventricular tachycardia. Which of the following is the best therapy? Synchronized cardioversion, unsynchronized cardioversion, lidocaine, amiodarone, procainamide. ECG is in front of you. Try to take your time, not in hurry,
Patient is
and
stable
give me the
or
answer. post your answer in the chat box so we can discuss. Yes, Dr. Noha, what's your answer?
Sir, unsynchronized,
Sorry?
unsynchronized cardioversion.
Unsynchronized cardioversion. Okay. So what are the indication of unsynchronized cardioversion?
Sir, VF.
Yes, Noha. What are the indication of unsynchronized cardioversion?
Sir, VF
If you want
ventricular fibrillation.
ventricular fibrillation. Any other?
Unstable VT.
Unstable VT, that is pulseless.
Pulseless.
Yeah.
Yes.
Fine. Any other indication where
Unstable.
you gone?
AF.
What unstable? AF.
No, sir, no, sir. This is synchronized.
Two condition. Pulseless VT and VF. For
Fine. So
unsynchronized
pulseless
cardiovascular.
VT and
Yes, sir.
ventricular fibrillation. Right. So do you think this is pulseless VT or ventricular fibrillation here?
VF.
They have not given that patient is a pulseless. VT is there. They are given ECG is VT. This is ECG of ventricular tachycardia. But they have not mentioned the vitals. So whenever there is not mentioned, means it is reasonably
It
okay,
is normal.
normal or okay. Whenever they have not mentioned, means reasonably normal. So now, do you change your answer or you are stick to your answer?
You have to change the answer.
Synchronized cardioversion.
It's a synchronized cardioversion.
So it's a change. Interesting.
Amiodarone.
No, sorry,
A.
Amiodarone.
amiodarone. Okay. So three answer. One is synchronized cardioversion from the audience. Another is unsynchronized. Third is amiodarone. So now tell me, sir, why you want to use the amiodarone in this patient? What is the advantage of the using amiodarone in this patient? Some logic is there, na?
The patient is stable. He has no.
The patient is admitted in the ICU and acute pulmonary edema. So do you think it is a stable patient?
Mm,
It's clinically stable. There is no.
Patient is, I think, amiodarone and the lidocaine is not used if patient is unstable. And
So by me, it's an unstable patient because
yeah,
patient is 80 years, patient has the acute pulmonary edema, patient has a
edema.
ventricular tachycardia, patient has
Yeah,
apical rest, patient has a jugular venous distension, so all bad signs are there.
yeah, sir.
Right. So now, what's the answer?
The ventricular tachycardia
Synchronized
itself is an emergency, sir. So we have to give a shock.
That is it. Yeah, that is
No,
very
it's just,
important.
yeah. A.
Okay. Little discussion, conceptualized discussion. Ventricular tachycardia or VTAC. Do you think when patient is stable and when patient is unstable, there is a change in the treatment or same treatment?
Change in the treatments.
Sorry?
There is a change in the
You
treatment.
can
Change, sir. Change.
change in the treatment.
Change
Wonderful.
in the treatment.
Change in the treatment. If there is a stability versus instability, change in the treatment. If patient is a stable, again,
Yeah.
next question comes, what is the definition generally for the stability? What do you mean by stable?
So there is no
Temperature,
chest
pulse,
pain.
BP, SpO2, sugar. There must be
There is
some
no chest
definition.
pain. There is no chest pain, and the blood pressure is it
No
is
chest pain.
normal.
Blood pressure is what? Blood pressure is what, sir?
Normal above 1 by
Normal. So let me clarify you. More than 90 is considered as a stable. Anything less than 90 is not stable. Right. So there is a no chest pain. Blood pressure is more than 90. Anything else which comes in the stability of the patient?
Altered.
You tell the patients that this is a stable patient. Sorry, I'm muting the all. So those who wants to answer, just unmute because some baby is noising background. Yes. Yes. Now you can unmute and answer.
So
So
chest
can
pain.
anyone tell me what is the definition of stable? It is clear cut given in the book. Very much clear cut. So two criteria are okay. There is no chest pain, blood pressure is normal, or better word is more than 90 systolic blood pressure. Reasonably
conscious.
they are considered
Patient is conscious.
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 Wonderful. So brain. This is brain. This is heart.
See,
Right? So blood pressure is good, right? And there is no chest pain. Patient is conscious. This is the general definitions of stability, right? Right. So acute pulmonary edema is not in stability. Acute pulmonary edema is not in criteria. So this patient is not stable. So this patient is like pulseless. Obviously, 100% it is unstable patients. Less than 90 systolic. Patient with a chest pain. Patient has altered mental status or loss of consciousness. Absolutely unstable. And patient has acute pulmonary edema is also unstable patient. Now, can tell me, now we got the definition of what is stable, what is unstable, right? We also get to know what are the criteria of stability and instability, right? Then what could be the treatment if the stable patients comes to you? What you gonna treat this patient? If unstable patients, how you gonna treat this patient?
So one question, sir.
Yes, please.
Sir, tachycardia is in the criteria, sir, for stable.
Sorry, correct. Tachycardia
Tachycardia
is?
is the criteria in the stable form, sir.
No, sir.
Okay, sir. Thank you, sir.
No problem. Yes, treatment stable, right? We are going conceptualize, so you can answer any question with VTech. So let me tell you, whenever any patient comes, any arrhythmia, whenever comes arrhythmia means what, right? Rhythm is altered. There are two category: increase or decrease. Decrease is bradycardia, increase is tachycardia. Bradycardia again, right? Bradycardia, tachycardia, atrial tachycardia, ventricular tachycardia. Bradycardia is likely ventricle usually anyway, right? So this you need to figure it out. So any atrial or ventricle, any brady or any tachy, any patient comes, your first answer, right, or algorithm start for any tachycardia. Let me give you this chart. Sorry, arrhythmia, either brady or tachyarrhythmia, right? It could be brady arrhythmia, it could be tachyarrhythmia. Arrhythmia means absence from the normal rhythm, absence from the normal rhythm. So abnormal rhythm, so abnormal could be low, abnormal could be high, right? So any arrhythmia, first questions asked to yourself in emergency room, whether patient is stable or not stable. Treatment start here from here only. It is not start here from, as the book says, patient is stable or not, right? If the patient is stable, different treatment. Patient is unstable, different treatment. Only the indication is one, but stability and instability completely 360-degree change the treatment. So stable VT. Anyone wants to try stable VT? What could be the treatment in general? You can tell me.
So
I think we
tachycardia.
give the procainamide, amiodarone,
Procainamide, amiodarone.
lidocaine,
and the
synchro.
lidocaine.
This is palm I created. It is there on our website, medical MCQ. P for procainamide, easy to remember. A for amiodarone, L for lidocaine, M for magnesium sulfate. Electrolyte disturbance can cause VT, magnesium. Is that clear? So you don't need to
Yes.
stress your brain now. Now, any patient in your exam comes ventricular tachycardia. Okay, fine. What's the first question? Stable or unstable? Stable, no chest pain, BP good, well conscious, fine. Select any of this, whatever given in your exam option. Probably they have not given amiodarone, they have given procainamide. So select procainamide. It is not possible that they have given procainamide, amiodarone, lidocaine. Impossible. They will not confuse it. Believe me, in exam. Exam is absolutely clear cut. Who confuse you? Yourself. Yourself confuse you only. You confuse yourself only. Nobody will confuse you. Believe me. Right? So you need to select either of these three or four, whatever they had given in the option, but usually procainamide and amiodarone is the closest choice. This is the amiodarone is one of the safest drug given for years and years for what tachycardia. If they have give you amiodarone and procainamide, then what? Then amiodarone is the drug of choice. Even if you go what ACLS BLS protocol after arrhythmia, if it is not improved after three shock, they will use the amiodarone. We'll discuss sometimes in BLS ACLS classes. Anyway, so this is the palm. Everybody is happy with this palm, yes or no? At least tell me yes or no.
Yes, sir. Thank you.
VT stable is equal to palm. Simple, one line answer. VT stable.
So,
Unstable patients,
so
right?
which is
What is
the
the treatment?
so which is the fastest drug among the four? So which one we should try the first?
Amiodarone.
Okay.
This unstable patient. Now this patient is unstable. Systolic is 80. Comes to the emergency, right? And it show QRS, 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 QRS. That is VT, right? Then what's the treatment?
DC, synchronized cardioversion.
Unsynchronized cardioversion, sir.
If the patient is pulseless, say for example, VT, pulseless VT, what is the treatment?
Unsynchronized.
Unstable but pulse is
Unsynchronized.
there.
Unsynchronized.
Unstable but pulse is there. There are two entity, na? Pulseless VT
Good.
and and VT with pulse. VT with pulse. VT with pulse. VT without pulse. So pulseless VT, what is the treatment?
Unsynchronized.
Unsynchronized cardiovascular.
Unsynchronized.
Unsynchronized. Only one. There are two indication. Just unsynchronized is very easy. Remember two things. Pulseless VT, VF. That's it. There is no third indication. That's it. Mug up. Unsynchronized pulseless VT, VF. That's it. Right. This patient has pulse. This patient has a right. So you need to give the synchronized cardioversion to this patient where the acute pulmonary edema is unstable but not pulseless, unstable but not pulseless, right? So this is the algorithm. Now you open up the any book, this will come in the picture, right? So you need to know the things, right? So here the answer is a cardioversion, synchronized cardioversion. Can anyone tell me finally what is the difference between synchronized and unsynchronized cardioversion? That is also confusing to a lot of people, so I want to understand your concept. Anyone? Open for all.
Sir, synchronized means it hits certain spots of the heart, and unsynchronized means it hits all the fibers of the heart.
Is
Synchronizing
there
is
any sorry, yeah, go ahead, sorry, go ahead.
in synchronized, we are synchronizing with the pulse, sir, or with the ECG R wave.
Mhm. Right, while in unsynchronized you are not synchronizing with anything. Anytime,
No,
any point of time, you just give the shock, isn't it? Yes or no?
limited. Yes, yes.
Excellent. So basically synchronized, you are synchronizing, or you see in your laptop na syncing photograph syncing, right? So they are
Anything
coordinating with
related
something.
to the power of the joules?
Yeah, so this is basically, as Dr. Amutul said, it is related with the cardiac cycle, R wave, right? So synchronize with the R wave, right? Unsynchronized, you can give anytime. Say, for example, one patient collapse, no pulse, no BP, cardiac arrest. You don't need to wait for R, Q, P, Q, R, S, nothing. Take the AD, give the AD. That's it. Unsynchronized. You don't need to synchronize with anyone. Right? So we'll discuss a bit more in detail. Probably it will take one more hour for me to speak on that. So probably in CPR lecture we'll organize. So you can demand on the group or to me directly what you exactly are looking for, right? Because I need to keep everybody in the loop. Now, everybody's understanding is different. So anyway, unsynchronized and synchronized. So you got the idea. Next question. Woman comes to the emergency department. So third homework. VT, VF. Read completely. These are absolutely life-saving and absolutely high yield for every exam, every time. There must be a question. A woman comes to the emergency department 1 hour after taking a bottle of pills. Blood pressure is 118 over 70. Pulse is 90. Respiratory rate is 14. She is confused, disoriented, lethargic. What is the most appropriate next step in the management of this patient? Flumazenil, gastric lavage, psychiatric consultation, naloxone dextrose, and intubation. Forget about G2K, we'll go later on. But first A to E, select anything. Take your own time. Put the answer in the chat box. Yes, Dr. Nasrin, what's your answer?
The time mention is 1 hour, sir. So then we can try for gastric lavage. If it is more than 1 hour, then we can go for
Okay, so let's discuss. Let's discuss. Let's
naloxone
discuss.
and
Let's
dextrose.
discuss. Fine. Yes, Dr. Nasrin. Gastric lavage. Gastric lavage. So, what are the indication of gastric lavage? What are the contraindication of gastric lavage? You start.
So contraindication kerosene oil.
Kerosene, okay. Kerosene.
If the
What
patient
else?
is not conscious,
Huh?
unconscious patient, and
Sorry?
disoriented patient.
Sorry, can you little give more clarity? Your voice is so slurred.
So she's telling unconscious patient, contraindicated.
Unconscious or mentally altered, na?
Yeah, yeah.
Mentally altered. It's contraindication. So this patient is disoriented, na? He is not oriented. Even though you want to give gastric lavage,
No, sir.
then why you selected gastric lavage then?
Yes, sir.
Sorry?
Yes, sir. She is.
No problem. So these all are the tricky and fishy points you need to keep in mind. Overall, your technically answer is correct, less than 1 hour. But for those patients who has not CNS manifestation, you understand? Some CNS manifestation means it is go beyond the gastric lavage. You get my point. We'll discuss. Anything else? Anyone else? Gastric lavage contraindications.
Sir, any acidic phenol or aspirin.
Corrosive poisoning.
Mhm.
What as per the book is corrosive poisoning. So these are the absolute contraindication where you can avoid, right? Why in unconscious? Because there is a risk of aspiration, right? Patient is unconscious. There is no gag reflex. They may aspirate and they may end up with aspiration pneumonia or ARDS, right? So this is the reason why you, right? So all rest of this all is indication. Now literature, the master the board and other literature showing when you have a poisoning, gastric lavage is what? This is esophagus, this is stomach, right? So this is pylorus, right? This is G junctions, right? Anatomy, right? So this is pylorus. So what happens when somebody ingested the poisoning orally, right? Up to 1 hour, exactly up to 1 hour or within 1 hour, you can remove 50%. Means what happens? Somebody had ingested 10 o'clock some poisoning and up to 11 o'clock, you can remove only 50% of the poison. Means 50% may get absorbed. Understand? Up to 2 hours, means 1 to 2 hours, beyond 1 hour, right? So 10 o'clock ingested, 11 o'clock 50%, and 11 to 12 o'clock next 1 hour, only 15%. Only. What does it mean? 80%, 85% plus may get absorbed, right? 85 and beyond 2 hours, contraindicated. No need. Why? Because 85 to 90% goes beyond the pylorus and may go into the systemic circulation, right? So what the benefit you will get when you are just washing and removing things, when 90% of the thing gets absorbed in the blood and now it's already in the blood and reaching up to the brain. You understand? Yes or no? Tell me yes or no. At least tell me yes or no.
Yes, sir.
Yes, sir.
So any patients
Yes, sir.
who has a any
Yes,
patient
sir.
who has a CNS involvement, something wrong, it goes beyond. Probably this is just the time frame for you to understand. For any questions, I'll give you all questions. By this understanding this question, you can answer 100 questions of poisoning, any damn sure poisoning come, you can answer easily. So CNS involvement means it is going confused CNS, disoriented CNS, lethargic CNS. So usually the gastric lavage is not the answer. If these three word were not there, then the answer is gastric lavage. Patient is stable, came within 1 hour, whatever you can remove up to 2 hours. So up to 2 hours you can answer gastric lavage in a mentally stable, conscious, well-oriented patients. Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful.
Sure.
Psychiatric consultation has no logic, right? And psychiatric consultation, when psychiatry will come and when he will advise you. And let me tell you one tips. Any consultation, any consultation is a wrong answer in any exam across the globe. Patient has a chest pain, call cardiologist, wrong answer. Patient has a bleeding, call hematologist, wrong answer. Patient has abdominal pain, call gastroenterologist, wrong answer. You need to treat first and then acute myocardial infarction, call cardiologist, wrong answer. What you need to do? Mona, morphine, nitrate, oxygen, and aspirin. Right? Cardiologist will come and he will tell you Mona, but he will waste 2 hours, and within 2 hours, patient will die because of VTVF. You don't need want your patient to die. So do something and then call. Do something and then call. Do something and then call. So never call directly specialist. This is the answer in all the books, international. And this is practical too, right? So if I'm sitting in emergency room, it is on Sunday, cardiologist went to the hill station with family. When he will come and when he will advise. You need to give something. You need to understand that give the Mona if nobody is available, PCI is not available, give streptokinase. That's it. Give thrombolytic. That is the answer in the exam. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. Now we have three options remaining: naloxone, dextrose, intubation, flumazenil. You can reshuffle your answer.
Intubation, sir.
Intubation. Okay,
Naloxone.
fine. Okay, so one is a naloxone, one is a
Sir,
intubation.
naloxone
Any
cannot be there because respiration rate is 14, sir. Naloxone depress the opioid depress the respiratory rate.
so why the respiratory rate is depressed? Then that is again a question. What poisoning do you think of? I mean, in general, when respiratory
The
rate is
opioid.
less,
Opioid.
opioid.
Yeah.
Wonderful. Opioid. So this patient could be opioid. You don't know, right? This patient is opioid, right? So what is that? Then antidote of opioid?
Naloxone.
Naloxone.
Naloxone antagonist.
Naloxone. Then why it is not a naloxone the answer? Somebody told naloxone is not the answer. General in discussion.
Because the respiratory rate will be more less, sir.
What is a normal respiratory rate? Let's
It's
comes to the
normal
basic.
only.
What is a normal respiratory rate in adult?
16, 14 to 16.
The 12
14
to
to.
16. 12 to 16.
So those who don't know the respiratory rate in adult, again homework, go and read the basic things. What is the
Sir,
normal
18 to
respiratory rate?
22.
18 to 22. Okay, fine. Fair enough. But still everyone go and read it. I know. 18 to 22. Okay, fine. So this is little low as per your thing. So why it is low? What poisoning can make the low respiratory rate? Somebody
Opioid.
told already, opioid. Okay, so when there is a opioid poisoning, you don't want to give any antidote of the opioid to the patient. Hello. When you are suspecting opioid poisoning, you don't want to give anti-opioid, yes or no? Tell me at least yes or no.
Yes, sir.
Hello.
Yes, sir, we
Yes.
have to take the
So answer is yes. Then answer is yes. Then what is anti-opioid or what is the antidote of opioid? It is given, my dear
naloxone.
friend, naloxone. It is given there, right? It is given there, right? Why not it is a flumazenil? Flumazenil, why it is not a flumazenil?
Benzodiazepine over there.
Benzodiazepine.
Antagonist of
Exactly,
benzodiazepine.
benzodiazepine. So here we are not suspecting any benzodiazepine, right? So flumazenil is gone. So these two options, ABC is a part of treatment. Obviously, ABC is always a part of treatment, any emergency. But
So how do we rule
important,
out benzodiazepine?
yeah. So there is respiratory rate. Respiratory rate is not normal. Number one, I mean respiratory rate is not that low in benzodiazepine, right? Number two, benzodiazepine is a prescription drug. Prescription drug, probably it is not available over the counter, right? Routinely, right? Even in India now, earlier people used to give, but now they are very strict. Without prescriptions of the doctor, benzodiazepine, sedative pills, sleeping pills is not available, right? So closest to this, right, is answer is a naloxone and dextrose. Let me tell you one another story related with this. Story means the fact about the things, right? So how you give any poisoning. Now let's come to the real learning here. Any poisoning, any questions related with the poisoning.
So sorry to interrupt. The answer for that one is naloxone.
Yes. Naloxone dextrose. How it? I'll come to that point as well.
Okay, sir.
We'll
Okay.
still not finish the question. Less than 2 hours, if any patient comes to you, your answer is gastric lavage, especially when patient is stable and no neurological symptoms or no contraindication, right? Or no contraindication. These are the two things where you can answer very comfortably that do go gastric lavage within 2 hours. Is that clear to everyone? Yes or no? Once it
Yes,
goes
sir.
beyond the two
Yes, sir.
hours, yes, it goes beyond the 2 hours in circulation or in the plasma. Most important thing is antidote along with supportive care. ABC is always there. I mean, airway, breathing, circulation, any emergency ABC is there, right? But we are talking about the specific treatment. So to answer any poisoning, fix in your head, you needed three things. At what time patient presents to the doctor in the emergency room? Number one, what drug or what poisoning agent patient used? And third question, at what dose he consumed the poisoning? Is that clear to everyone? Yes or no? I'll elaborate each and
Yes,
every point properly. So until and unless you know these three things, you will not going to give the correct answer to any poisoning questions, whether it is aspirin, paracetamol, ethanol, organophosphorus, opioid, whatever. You name the poisoning, you cannot answer. You need to know three things. So now onwards, anywhere, we'll go back to the scenario as well, just to clarify this. Why time is important? Because on the time frame, how patient comes, 0 hours, 1 hours, 2 hours, probably you go for gastric lavage. Beyond 2 hours, you may probably go for antidote. That is why the time is important. Second, right? Antidote, you can consider the antidote, but when you consider the antidote, when you know the drug. Few example, opioid, naloxone, organophosphorus poisoning, right? Atropine, palm. Have you heard of it? Yes or no? Tell me at least yes or no, right? This is second. Third example, acetaminophen, antidote, and acetylcysteine. Iron overload, iron poisoning. You need to know.
Desperoxamine.
Yes, desperioxamine. Right. So these are few examples. Lead poisoning. Can anyone know lead poisoning antidote? Can anyone know copper
DM,
poisoning epiload?
penicillamine. Copper
Penicillamine for lead
penicillamine.
or copper? Copper penicillamine.
Copper
Lead,
penicillamine. That is DMSA.
EDTA,
lead
EDT.
poisoning.
EDTA,
This is just guess or answer.
No, EDTS.
EDTA.
Okay, so this is homework for everyone. I want to give you the concept that you need to know the completely common abuse drug. Aspirin is also commonly used as a poisoning overdose. Insulin is also used, especially by doctors and medicos, right? So these are the common poison. You must know the antidote. So that is why you need to know. Now, I'll tell you, patient consume poisoning. Then what antidote will give? If it is acetaminophen, your antidote will change. If it is iron, antidote change. If it is a opioid, antidote change. If it is OP, or right,
So poison of, sir,
antidote
yeah, cyanocobalamin antidote. We give cyanocobalamin. I'm forgetting the
for
names.
what?
So we
For
give
what?
the cyanocobalamin.
Cyanocobalamin for what?
Yeah, I'm forgetting the name, sir. The poison.
No problem. Homework,
Sir,
homework.
lead is DMSA, sir.
Sorry,
Succimer. Lead is Succimer, DMSA.
DMSS, Saximan. Google it. Did you Google it?
No, I just read yesterday. I didn't remember.
Sorry. I'm just joking. Don't take it otherwise. So
No.
time
Sir,
is
lead has no
important.
antidote. Only chelating agents has to be used.
Okay. So time, I told you the logic of time. Drug agent, why you need to know the name of the drug? Because depends on the drug, antidote will change. And why is the dose? Right? Because dose, three dose, therapeutic dose, toxic dose. I'll give you example. And fatal dose. One example, paracetamol. Patient comes with the excessive paracetamol overdose after 2 hours to the emergency room, right? Patient is conscious, well oriented, right? So, paracetamol, means drug or poisoning agent, time, 2 hours, time, and patient has taken the 8 tablets of 500 milligrams. So, now you dose also, Three things, time, patient came within 2 hours, drug, acetaminophen, and dose 8 tablets of 500 milligram each, means 4 gram. Therapeutic dose is 4 gram,
Grams.
toxic dose is 10
10 to
gram,
50.
fatal is 15 gram.
20.
So now, so somebody is coming to me in the emergency that I have taken a 6 tablet in 24 hours. This drug is in 24 hours, huh? 24 hours. So within 24 hours, I took 6 tablet of paracetamol. He panic, right? No need to get panic. 4 is therapeutic dose. Even you can give in high grade fever, right? Say for example, 1 gram morning, 1 afternoon, 1 evening, and 1 night means 4 gram in 24 hours is a therapeutic dose. You don't need to do anything. It will excretate, metabolize, and excreted from the urine and stool. No need to get panic. So you need to have a line of demarcation. What is therapeutic? What is toxic? And what is fatal? So toxic and fatal is a matter of concern, not the therapeutic. Is that clear? Yes or no? Is that clear? Yes or no?
Sir,
Yes.
Right? So when patient comes to you with 4 grams, you don't need to do gastric lavage. Even if it came immediately after taking in 24 hours 4 gram, right? It's a therapeutic dose. No heart, no liver, no kidney, no brain will damage. It's a therapeutic dose. Body can metabolize. Excessive cannot metabolize, and that produces the toxicity. And this is the dose. This is the dose. This is one example of acetaminophen. Like anything, you have this. So these three things you must keep in mind. Any questions or query with this so far? before going to the next slide?
So
Everyone
what
is
is
clear?
role of sir activated charcoal?
1 minute. Coming also. So now I told time, then drug or agent, and dose. Now remember, one patient comes to you, or question is 20 years female, found unconscious, right? Suspected poisoning, right? Notice in the bedroom, unconscious. How you gonna manage? Where time is not mentioned, you don't know time. This 20 years female alone in the house, found unconscious. They don't know what drugs they consume, and they don't know what the dose they consume. How you gonna approach this patient? Exam questions. You don't know anything. It's possible, no? It's possible. It's possible. How you gonna manage this patient? Anyone?
So first of all, take the vitals and then intubate, send the blood for ABG and all the electrolytes.
Okay, everything is done. All investigation has been done.
So urine for toxicology.
That is also done. Inconclusive. Urine for tech. Give me the test name. I will give you the result. You right. So for your better understanding, urine toxicology inconclusive. Blood toxicology inconclusive.
Sir,
We
flumazenil.
cannot reach to. Huh?
Flumazenil.
Sorry.
So
Flumazenil. Why flumazenil? Why?
something universal.
What universal?
Benzodiazepine are the most common drug that are being abused among this age group. Maybe the
Which
sedative.
country?
Say activated charcoal, sir.
Okay, activated charcoal. When patient is unconscious, do you think the activated charcoal will help to this patient? Already goes up to the brain, because charcoal, how charcoal? It reduces the absorption. That's it. So charcoal and gastric lavage by and large the same indication. When you cannot do the activate gastric lavage, you may probably give the answer activated
So
charcoal.
intravenous chelation.
Fine. So let me answer these questions. There is a protocol when the time don't know, when the drug or agent don't know, when the dose don't know. The protocol is named as a like PM PALM. It is called as a TONG, TONG, or cocktail protocol. Cocktail. T stands for thiamine. Thiamine, if I am not wrong, it's a vitamin B1. Why it is vitamin B1 in this cocktail protocol? Alcohol poisoning is one of the most frequently done world over. Alcohol, and patient develop vernix and encephalopathy. Right, one of the most across the globe. I'm talking. O for oxygen, and for naloxone, G for glucose. Naloxone opioid is one of the frequently abused drug for pain and for the recreation, and insulin overdose is again a very common across the globe. Right, so this is the tongue protocol where you can, when you don't know anything in your emergency, patient brought unconscious or found unconscious, no history is given, no history giver is available, they absolutely find, and you are suspecting some kind of poisoning, absolutely no harm, even though it is not vernix and encephalopathy and you give B1, no harm. If you give 2 to 5 liter of supplemental oxygen to reduce the hypoxic brain and other organ injury, no problem. Even if there is no opioid poisoning and you give naloxone, it won't help. And if you excessive give the glucose, even little overload glucose, patient will not die. But if something is out of this four, and if you missed, he will die. So this protocol comes in the picture globally, right? When you don't know nothing, you knows nothing, no time, no drug, no dose, nothing. Use the tongue protocol, and keeping this concept in the mind, let's back to the question. What drug here used? Can anyone tell me what drug used? Can anyone tell me which drug patient took? Anyone?
Opioid overdose.
Opioid.
We don't know. We don't know basically, right? We are suspecting, right? Taking bottle of pills, but what drug? We don't know. I mean, ideally, we don't know. They had not given any drug. This is what our suspicion is. This is what we are thinking that it could be opioid. Fair enough. No problem. Then blood pressure. Sorry. So we don't know the agent, right? Timing
1 hour.
1 hour.
1 hour. So reasonably we had a time, but patient has a CNS symptoms, right? And dose we don't know. So dose we don't know, drug we don't know, time is only we know that within 1 hour or so. So context of these questions, the most appropriate is the tongue, where even you suspect that it is a opioid poisoning, naloxone is the things, even insulin overdose, the dextrose is there. So always keep in the mind when three things are not clear: time, dose, and these things, right? So here the answer is naloxone and dextrose, not A, B, C, and E, right? So this is what the basic of all complete whole poisoning. So you need to know what is fatal dose for common one. You don't need to mug up hundreds of poisoning. Common one: insulin, aspirin, opioid, right? And acetaminophen. These are the absolutely high yield question in the exam, right? So you need to know, and you need to know the name of the antidote. So here the answer is I told you everything, right? What happens? The best initial management of the altered mental status of unclear etiologies, opioid antagonist, and glucose, right? So that's it for this. Flumazenil reverse the benzodiazepine, right? So here the flumazenil is not the case. So that's it. So I discuss one more last questions probably and end up the session here. A 75. So another homework. Go and read complete chapter of poisoning from Master the Board, USMLE step 2 or 3. Whatever I told you, 99% of the things you can recollect while reading each and every word. So you revise it once again just to get minute more details. I try to give you the overall lookout of the poisoning overview. 75-year-old man is admitted to the hospital with pneumonia. Several days after the start of antibiotic, he begins to have a diarrhea. The stool culture shows Clostridium difficile toxin is positive and is started on the metronidazole, which leads to resolution of diarrhea over a few days. 2 weeks later, diarrhea recurs and Clostridium difficile or C. difficile toxins is again positive. What is the most appropriate next step in the management of the patient? Repeat the dose with metronidazole orally because it's a recurrence, earlier responded well. Use vancomycin orally. C. Do sigmoidoscopy and treat only if there is a confirmation of Clostridium or pseudomembranous colitis. IV metronidazole oral is not working now, recurrence, so you switch to IV. You want to do stool culture and then you want to do something more, and you may probably go for intravenous vancomycin. Yes. Think over it, not in hurry. Take your time, 10-15 seconds, half a minute. What do you want to do for this patient? Yes. What do you want to do for this patient? Anyone wants to try? Last for the today. Dr. Noha, what's your comment?
See option C, sigmoidoscopy and treat only if pseudomembranes are found.
Okay, sigmoidoscopies. So why you want to do so much of aggressive things to confirm? Because 2 weeks later the diarrhea recurs and C.
Again, it is
Clostridium difficile is again positive. stool, it's again positive. Then what is the advantage of doing the colonoscopy or sigmoidoscopy in this patient? They did culture or they did some stool antigen positive CDP. They said na, 2 weeks later the diarrhea recurs and Clostridium difficile toxin is again positive. So I'm just trying to understand what additional information you're gonna get from doing the sigmoidoscopy in this patient. You did sigmoidoscopy. What you will see?
So, that is what we'll be able to find if there is any finding in sigmoidoscopy, because why it is occurring again and again.
Not
Maybe
again
there
and
could
again,
be
just once it occurs.
erosion or I don't know.
Before sigmoidoscopy, would you like to try something or just gonna go for sigmoidoscopy only?
So culture would be an option.
Culture would be an options. Okay, culture. Okay, so did culture grows Clostridium difficile? Do you know? Do you have
No,
any
sir.
idea that culture will grow the Clostridium difficile? Homework. You go and find out that how is it the normal culture will grow Clostridium difficile or not? Go and find out. Fine. Anything else? Any other things?
Sir, oral
The
vancomycin.
Vancomycin, sir.
oral vancomycin. Okay, so now tell me, somebody replied, two, three girls. So why oral vancomycin you want to give and why not repeat metronidazole? Because it is earlier, previously it is effective, no patient is fine. But again it recurs. So why oral vancomycin?
Sir, if unresponsive to metronidazole, then we go for oral one.
Sorry?
If it is unresponsive to oral metronidazole, then we go for oral vancomycin.
Okay. So you would like to go for answer A or answer B?
A.
Sorry?
A.
A. Okay.
Oral
Anyone
vancomycin.
else? Anyone else? Last comment. So some people is saying culture, someone is saying sigmoidoscopy, metronidazole and vancomycin. So just quick review: hospital acquired Clostridium difficile, community acquired and recurrent. Not going much in detail. Recurrent episode of Clostridium difficile associated diarrhea is best treated by the vancomycin. This is guideline. Number, intravenous metronidazole is not required. Usually, intravenous metronidazole is only if oral therapy cannot be used. So when oral is contraindicated, give intravenous because probably the penetration in lumen is not well. Such in a patient of adynamic ileus, right, or paralytic ileus, where oral is contraindicated, you give IV. Stool is never culture for Clostridium difficile because it simply will not grow in the culture. So those who have a concept of culturing the stool for Clostridium don't do, because Clostridium will not grow in the culture. They need special media. Stool is never cultured for Clostridium difficile because it simply will not grow in culture. The difficulty in culturing Clostridium difficile is the source of the name of the organism. Endoscopy looking for pseudomembrane will diagnose antibiotic associated diarrhea, but it is not necessary step given the availability of the stool toxin assay. So when stool toxin assay is not there, you may go probably to find out, but stool already again second time positive means you go and jump for the treatment, not the investigation. Intravenous vancomycin is always a wrong answer for antibiotic associated diarrhea. Why? Because it will not pass to the bowel wall. And oral vancomycin, right? And the treatment of Clostridium difficile has changed is that the metronidazole is no longer as a first line single agent. This is because both vancomycin and fidaxomicin has better efficacy than metronidazole, and that's all. That is the guideline and answer. So that's all from my side. Thank you very much for today. Before I close my session, I have many things to discuss, but probably it's 1.5 hours I'm speaking. So let's get to little quick
So what was
feedback
the
from the
answer, sir?
audience.
So what is the
Answer
So what
is
correct
was the
oral
answer?
vancomycin, sir. Oral
But
vancomycin is the answer.
in the key it is written A, sir.
Oh, what? is not written here, but even if it is written, it is not the answer, right? So oral vancomycin is the treatment of choice.
The one
Right?
before. Yes, sir. The correct
Right.
answer is
Yeah.
A.
B. Correct answer is B. Metronidazole is not now in any guideline. Now you open up the book. If you have something different, I would be glad to have this on the things. Fine, right? So just give a quick feedback about this lectures. If you are, I mean, just spare 1 more minute, I would be glad. Anyone?
So you told to take the exam for in your website, sir.
Sorry?
So you told to take exam mock test in your website
Yes, sir.
that was available till 17th of
I
Jan.
will extend it, sir. I will extend it. Those who have missed, I will extend the date
So we have
and
taken
make
the
it
exam, sir. I've taken the exam.
wonderful. Send me the score later on. We'll review it.
Okay, sir.
How was your experience today? That's the question.
So it was very
Sir,
good, sir. So I always have a
Very
confusion
informative,
between
sir.
Addison disease and this Cushing syndrome, sir. Today I am sure that I won't make any mistake in these two parts.
Wonderful. You are a very brilliant man. Great. Wonderful. Anybody else? How was the experience? Something new learning which you never, I mean, thought of, or something which makes you little more. No one. Means I need to improve a lot.
So
The poisoning topic was very good, sir. It gave us a lot of information. The silly
Okay.
mistakes which we did in our exams, that we can make it out now.
Wonderful. 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 So just concentrate on the weaker parts. Yes, Amutul.
Yes, sir.
Yes, Noah.
So all the scenarios starting from the DKA, Cushing's, and the VFVT, and all the pictures, including poisoning, were very fresh, and it was almost like learning it again back.
Wonderful. Thank you very much. Yes,
So,
Dr.
so this
Sama.
Gulf exam says more about the making the silly mistakes, sir. I'm saying that silly mistakes are very common, sir. With your classes, it decreases a lot.
Wonderful. Thank you very much for your kind feedback. Great. Yeah. And need to concentrate on the high yield as well. Yes, Amutul.
Sir, for that mock test, how do we, if we want to just recheck everything again, can we access to it, sir?
I
Can
will
we get an
make
access?
we can I can make extend the expiry date of the mock test, so it's available. I'll do it
Okay.
today or tomorrow.
Okay.
So you can
Thank you
review
so
and
much.
you can assess the same questions. No? But once you give, see, I'm not saying you don't know anything. You knows everything, but we did a silly mistake, no? And that
Yes, sir.
reduces the
Yes, but
score. So this is
I got,
real.
I want to check what mistakes I did, sir. I
Fair enough. Fair enough. I'll
could not do
open
it.
it. I'll open it. Yes, Nasrin.
Thank you so much, sir.
You're welcome.
It was really a wonderful session, sir. We have to come lots of ideas about the poisoning, then VT. So it is really helpful so much, sir. We did a lots of mistake. Like we know the things, but still we do the same mistake again and again. So it is helpful, sir. Thank you,
Fair
sir.
enough. Yes, Dr. Sama, Dr. Sunil, Dr. Jamila, Javed, Qureshi, Jonah, JMJ. Lots of doctors in the group. 27, 8 people are there on the Sunday.
Today I learned from the more things from the poisoning thing. First of the gastric lavage contraindication. I don't know the lavage gastric is indicated in the unconscious person. It is great for me today.
Fair enough. Thank you very much. Yes,
Thank you,
Dr.
sir.
Naush, Sayyed.
It's very helpful, sir.
Thank
Just
you very
for
much.
even if it is you might have forgot that if you are like me, even you are completed our UG like some 10 years back, and it's giving an opportunity to brush up the information whatever we learned in the past, and
Great.
it's a good opportunity. That's a very good
Very nice.
presentation, sir. Thank you.
Anyone last? Anyone? Great. Fine. Thank you very much. I'm flying to UAE as well. Those who are in Dubai, Next Sunday I'm flying on the same time. So we'll catch you in Dubai. Those who are nearby Dubai, Sharjah, uh, hopefully to see you. This is my number. Those who don't have my number, this is my number on the bottom. This is 9825578080. The same number will operate in Oman, sorry, Dubai and Abu Dhabi and UAE. Mobile, you can drop me message. I can call you, no problem. So those who are willing, I will be there to attend the Arab Health and few other things of more development in DHA, HAD, So keep in touch, stay tuned if you are nearby. I will be there in Dubai from 26th of the January to 1st of the February. So almost 1 week. So we'll see you. It's my pleasure to meet you as well. Just drop me message. We can connect, we can talk, we can meet face to face as well. So we are planning to make one meeting with the local Dubai doctors. So let's get connected. I will share the locations, right, which is like accessible to everyone, probably the Barjuman. But I will update you with the date and time so we can meet and we can have some snacks, tea, coffee. Thank you very much, doctors, and stay tuned. See you for the next lectures. Goodbye.
Thank you, sir.
Thank you, sir.
Bye bye. Take care.